The next cyst in the list is OKC or Odontogenic keratocyst. So in the 2005 WHO classification, OKC was taken back and it was classified under the tumors and it was renamed as keratocystic odontogenic tumor, whereas in the latest 2017 classification, it has been again called as OKC or odontogenic keratocyst. The term odontogenic keratocyst was first coined by Philipson in the year 1956, and the features of this tumor was first described by Pinborg and Hansen in 1963. Clinically, this comprises around 3 to 11% of all the odontogenic cysts, and 60% of these cases are diagnosed in people between 10 to 40 years of age with a male predilection, and around 60 to 80 cases are more seen in the mandible and again in the posterior body and the ascending ramus. Radiographically, it appears as a unilocular radiolucency as well as with a multilocular radiolucency also. The unilocular radiolucency with a well-defined peripheral rim can be seen, and in such cases, it resembles like a dentigerous cyst, and multilocular cases resemble like an ameloblastoma. So it has four radiological variants. One is a replacemental type where the cyst will form in the place of a normal tooth. Second is an envelope type where it embraces over an unerupted tooth. Then third is an extraneous type. Here it appears over the ascending ramus that is away from the alveolus or the teeth region. Then last is the collateral type, whereas the cyst is present adjacent to the root of the teeth. So this will be a replacemental one, and this is an extraneous one. You can see it is in the ramus area, and these are the collateral ones, mimicking like our lateral periodontal cyst. And this is the envelopmental type that is discovering the crown of an unerupted tooth. So this is extraneous, this is replacemental, and this is envelopmental, and this is collateral. An FNAC or fine needle aspiration cytology will be done for these OKCs, which shows the presence of a thin straw-colored fluid or sometimes with a thicker creamy or cheesy material because of the presence of high amount of keratin in the cyst. And under the microscope, you can visualize this kind of needle-shaped rectangular shaped structures called as the cholesterol crystals and hyaline bodies. Histologically, OKC shows a parakeratinized stratified squamous epithelium with corrugations, and there are no retipecs seen. And the epithelium usually will have around 6 to 10 layers of thickness, and the basal cell, if we visualize, it shows a proper picket fence or a tombstone appearances. And under the capsule of the cyst, it shows the presence of numerous satellite or the daughter cyst. These are the epithelial rest and proliferating dental lamina. So you can see multiple satellite cysts in the capsule. So there are syndromes which are associated with the multiple OKCs are noted, which includes a Nevoid basal cell carcinoma syndrome, orofacial digital syndrome, Simpson-Gulabi-Bemel syndrome, Ehlers-Danlos syndrome, Marfan syndrome, Gallin syndrome, and Noonan syndrome. In all of these syndromes, there are the presence of multiple OKCs which are seen. And OKC is a cyst which shows a highest recurrence rate of around 13 to 60 percentage, and more in the cases where it is been associated with nevoid basal cell carcinoma syndrome. And if it is in the mandibular, molar, ankle, or ascending ramus, again it has a highest recurrence. The reason noted for this recurrence is one is there could be the epithelial rest or the remnants which are left behind in the cyst even after the excision. One reason could be the limited surgical access to the posterior part of the mandible and the presence of the satellite or the daughter cyst, or there could be a continued proliferation of the dental lamina. All these could be the reasons for the recurrence of OKC. Treatment: there should be complete surgical excision of the lesion with marsupialization or enucleation and primary closure of the lesion or enucleation and package or the packing. A 5-year follow-up is mandatory to check in for the recurrence rates. So this is a nevoid basal cell carcinoma, wherein the patient will have multiple OKCs with Fox cerebrae and palmar pits, and you can see a lot of cutaneous nevi over the patient's skin. These are few other pictures. So we shall do one question regarding this OKC. So the question is, the most ideal explanation for the recurrence of OKC is increased mitotic activity of epithelial lining, friability of epithelial lining, presence of satellite cyst or daughter cyst, continued proliferation of rest of dental lamina. So among the options, the most ideal one, or which is more favorable for the recurrence, is the continued proliferation of rest of dental lamina. Another one lesion which is similar to this is known as a orthokeratinized odontogenic cyst or OOC. This is a distinct and uncommon odontogenic cyst of the jaws arising from the remnants of dental lamina, appears solitary, usually asymptomatic, with a swelling. More commonly seen in third to fourth decades, more in males and more in mandible region, and more commonly in the molar areas in the impacted tooth. And this OOC, in contrast to the OKC, this is not associated with any syndromes and radiographically usually shows a unilocular radial recency. Pathogenesis, it could arise from the oral epithelium or from the dentigenous cyst which has an orthokeratinization. So we shall see few differences between this OKC and OOC. OKC is normally associated with the syndromes, whereas OOC is not. It isn't that OKC will always be associated with syndrome, no, but OKC can have an association. OKC under the histopathology, it shows tall columnar cells with palisading patterns, whereas in OOC we normally see a flat cuboidal cells. In OKC, there is presence of satellite cyst and the cell shows increased mitotic activity, whereas in the OOC, you have a beautiful orthokeratinized epithelium which shows a prominent layer of stratum granulosum. So this is however OOC appears under the histopathological. You can see a thick layer of orthokeratin above the superficial layer of epithelium, and the basal cells are more of low and cuboidal, and the presence of this higher amount of orthokeratin gives it an onion skin appearance, and it shows a very beautiful prominent stratum granulosum. So this is the orthokeratinization and prominent stratum granulosum with the basophilic keratohyalin granules and the flat basal cells or cuboidal cells. Treatment again is a simple enucleation. Cyst is neither aggressive nor a recur condition. So we shall do one more question. Bifid ribs, multiple radiolucent lesions of the jaws, multiple basal cell nevi, and Fox cerebri calcifications are found in Stewart-Weber syndrome, basal cell nevus syndrome, Horner syndrome, hereditary intestinal polyposis. So all these are the features of basal cell nevus syndrome or nevoid basal cell carcinoma syndrome. Eruption cyst transforms into dentigerous cyst or regresses after eruption of the tooth or is found in the place of missing tooth or is a type of dentigerous cyst. So eruption cyst is now considered as it regresses after the eruption of the tooth. Garland cyst is synonymous with OKC, LPC, COC or GOC. So Garland cyst is nothing but calcifying odontogenic cyst. GOC or glandular odontogenic cyst derives from rest of cere, rest of malaceae, reduced enamel epithelium or oral epithelium. It is from the rest of cere. So that comprises the list of developmental odontogenic cysts. That is dentigerous cyst, gingival cyst, lateral and botryoid odontogenic cyst, glandular odontogenic cyst, calcifying odontogenic cyst, odontogenic keratocyst, and orthokeratinized odontogenic cyst. The next classification is the inflammatory odontogenic cyst. So under inflammatory, initially we had radicular or periapical cyst, residual cyst, and the collateral cyst. And in the latest update, we have only the radicular cyst and the collateral. So what is basically a radicular cyst? So radicular cyst is also known as an apical periodontal cyst, periapical cyst, and a root end cyst. And this is considered as the most common odontogenic cyst encountered in a dental clinic. The most common odontogenic cyst is a radicular cyst, whereas the most common odontogenic cyst under the developmental category is only the dentigerous cyst. And this comprises around 60% of all the jaws and 15% of all the periapical cysts. More commonly seen with an age group of 20 to 60 years, and the teeth involved mostly are the maxillary anteriors, mandibular premolars, and the molars. So the pathogenesis or formation of this dentigerous cyst is considered as any kind of an inflammation or a trauma. It can be caries, a trauma, periodontal disease, which is causing a pulpal necrosis. So that would lead to an inflammation in the periapical region, followed by formation of a periapical granuloma. Periapical granuloma usually comprised of a granulation tissue and lots of inflammatory cells, and which will provide a rich vascular area in the periapical area, which will activate our cell rest of Malassez, which is in that periapical region. So the cell rest of Malassez are nothing but the remnants of our Hertwig's epithelial root sheath after the root formation. So these cell rest will start proliferating as a result of that, and it is forming a cyst eventually. So as you can see in the picture here, this is the periapical area. These are our cell rest of Malassez, and they are proliferating, and there are few cells which are actually undergoing a degeneration in the center, which is creating a cavity, and it forms a epithelial lined cystic cavity. So these cell rests will form a large mass of cells. What happens when it is increasing in the size? The cells which are in the center area or in the inner area will be deprived from the nourishment coming out from the connective tissue area. So what happens? The cells in the center will undergo a liquefaction necrosis, and that will form a cavity in the center of the area, which is becoming a cyst. So there is a cavity in the center, and surroundingly you have those epithelial cell rest which are proliferating, and next to that you have the vascular supply which is coming from the connective tissue, and that creates a cyst. So the pathogenesis or the formation of the cyst is being explained in three phases, which includes a phase of initiation, phase of cyst formation, and phase of enlargement. The phase of initiation is nothing but there is a stimulation which will proliferate the formation or which will proliferate the cell rest of Malassez. Whereas in phase of cyst formation, the cells in the center, as and when it proliferate into larger mass, the cells in the center will be lacking from the supply or the nourishment, and it undergoes a necrosis. And in the cyst enlargement, you can see there is a large cavity which is formed in the center, and you can see an epithelial lining, and next to that you have the capsule or the wall of the cyst, and it expands. This is a similar picture which again shows the same features. Proliferated cells, center one undergoing necrosis, and which is creating in the formation of a cyst. Radiographically, it will appear as a round or a pear-shaped unilocular radiolucency with a diameter of 1 to 1.5 centimeters associated with a non-vital tooth. Histologically, it shows a layer of stratified squamous epithelium, and if it is being associated with a sinus, then you can also see a pseudostratified ciliated columnar epithelium. Usually, it shows a high proliferation, so the cellular layer thickness can go even up to 5 to 50 layers, and it shows a particular pattern known as arcading pattern, and you can also see those hyaline or the rostrum bodies here. So this kind of a pattern of the epithelium of highly proliferated non-keratinized stratified squamous epithelium in the radicular cyst is referred as a arcading pattern of epithelium. And you can see the presence of hyaline or the rostrum bodies. So to conclude, under the histopathology, you will have a hyperplastic proliferative cystic lining which shows the typical arcading pattern, and under which you will have the inflammatory cell infiltration, predominantly the lymphocytes with a fibrous connective tissue. And if it has been associated with the maxillary sinus, you would also see a pseudostratified ciliated epithelium with presence of mucus cells. So treatment is root canal treatment of the involved tooth followed by periapical curettage. If the cystic sac is badly fragmented, then there can be the remnants of epithelium which is left behind, and that can later proliferate and form another cyst even after the extraction of the tooth, which is known as a residual cyst. And if the cyst is being left untreated, usually these radicular cysts will increase in size and it will expand to the expense of the surrounding bone. So residual cyst is nothing but a type of inflammatory cyst only, but it occurs in the edentulous alveolar ridge due to the reason behind is when there are these epithelial remnants which have been left out even after the extraction of the tooth. That can lead to another proliferation and forms a cyst. So something like this. You can see there it's an edentulous area, but there is a cyst in the apical region of the. So that is a residual cyst. Treatment again is a complete cystic curettage. Next one is known as an inflammatory collateral cyst or a paradental cyst or a buccal bifurcation cyst. And this is again a radicular cyst at the lateral canal of the tooth root. More commonly seen in the third decade with an age group of with an average range of 10 to 30 years, and it is present in the distal or distobuccal to the mandibular third molar region. Usually the tooth is vital in nature. It is supposed to be originated from the cell rest of Malassez or from the reduced enamel epithelium, and pathogenesis cause a unilateral expansion of the dental follicle, or it can be a variant of dentigerous cyst, or it is formed due to the inflammation due to the pericoronitis of the unerupted tooth. It could be any of the reason for any of this could be the reason for the development of the cyst. Buccal bifurcation cyst is also known as a juvenile paradental cyst or a mandibular infected buccal cyst. More commonly in mandibular first molar region, less than 15 years of age. So herein there is an inflammation happens in the or due to eruption or due to a periodontal pocket which is activating the proliferation of cell rest of Serrae or a cell rest of Malassez, which causes a hyperplastic odontogenic epithelium and leading to the formation of a cyst. This buccal bifurcation cyst is normally seen in the mandibular molar region, and it involves the percussion areas of the buccal surfaces of the molars, and it shows a semi-lunar radiolucency on the buccal surface. Okay, so that comprises our list of developmental and the inflammatory cysts under the odontogenic categories. So these are few radiographical pattern like pictures wherein we can see one by one what it indicates. So in the first picture, we actually see a different radiographic pattern. One is being attached to the root region, and one is away from the tooth region, and one is surrounding the crown. So these kind of different patterns of radiolucency we see under the OKC, which has the 4 different radiographical patterns. Whereas in second picture, you can see there is a radiolucency attached to the periapical area, and if you observe, there is a periapical lesion or the tooth is being inflamed. So that will go for a radicular cyst. Whereas in third picture, again it is in the periapical area, but there is no tooth which is seen associated with the lesion. So it will go for a residual cyst. Whereas in this picture, we can see an impacted tooth that is being covered by the radiolucency. So that will go for our dentigerous cyst. Whereas in this one, all the teeth are being erupted. So you see a cyst in the overlying epithelium. So that will go for a soft tissue cyst, that is our eruption cyst. And herein, you see the cyst which shows a lot of calcifications. So that will go for a calcifying odontogenic cyst. Here again, it is seen in the overlying epithelium or in the oral mucosa or in the gingival region, you see the cyst. So that will go for a gingival cyst. Here, the cyst is present in between the teeth or in the lateral surface. So that will go for a lateral periodontal cyst. Whereas here also you see the cyst in the lateral region, but they are multiple in nature. So that will go for the botryoid odontogenic cyst. Whereas in the last picture, you see the cyst, but you can also see some presence of glands within it. So that will go for your stylo-odontogenic cyst. So With that, we conclude the odontogenic cyst classification and the detailing. Thank you.